Top Med Talk.
Well, hello, I'm Desiree Chappell, and this is Top Med Talk. As the coronavirus pandemic continues, we are continuing our conversations with care providers around the world to shed light on the crisis. Our series, COVID from the Frontlines, highlights healthcare workers that are either on the ground themselves or in a more supportive role, and we really want to share their stories in hopes to provide education and support for all of our global listeners. Now, I'm in Louisville, Kentucky, but I'm joined by our editor-in-chief, Monty Mythen, in London, England. Hello, Monty.
Hi, Desiree. How are you today?
I'm doing okay. How are you doing? You staying busy?
Yeah, all very busy, all busy in a good way. Let's say this weekend was the first weekend where really things have calmed down a little. Now, that sounds as though, problem over, but I don't mean that by any way, shape or form. What I mean is the stuff coming in the front door seems to have lessened. And my colleagues who are in there doing critical care right at the sharp end are still working incredibly hard. There's a lot of sick people, but the number don't seem to be growing at the moment. So London, we do get the impression this weekend for the first time is that the surge for phase one, as we're calling it, may be over. Now, that having mixed up in parallel, we started scheduled surgery a number of weeks ago for cancer patients in two of our networked local hospitals, and that's still going really well. So far, we've been ultra cautious about the whole thing, going way over the top with protecting patients from us, us from each other and all that stuff that goes with COVID-19. But touch wood, so far, that's going really well.
Oh, that's great, Monty. Are you guys talking about starting elective cases here shortly? Because here in the U.S., here in Louisville, Kentucky, I think within the next week or two, they have decided to start ramping things up.
I'd say slowly, as part of this is the phase they're talking about now is easing the lockdown. So as we ease the lockdown, part of that natural experiment is will we see a second spike in COVID-19? So we don't want those things to happen at once. We are, increasing, we're getting through the scheduled cancer surgery in particular and other scheduled surgeries, and we're looking towards getting elective surgery done. Now, as part of that, we're using this quiet period to say to people, let's get yourself really well prehabilitated for surgery. Let's do all of those good things that are going to make your joint replacement so much more successful when you have it. Let's take the time to get exercising, get, if we can, get anemias fixed and all those good things.
Yeah, well, we all have our list of patients that have been waiting, that were either canceled or not. So we know that there's a group of people that we could potentially reach pretty quickly about optimizing them. So, we'll save that conversation for a little bit later in our podcast today. But Monty, staying true to our global perspective of what's happening on the ground regarding coronavirus, our next guests come to us from New York City, the epicenter here in the U.S. And obviously, most people have seen the news about what's happening there. But today, we're really honored to have not necessarily just care providers that live in New York City, but that come to us from the United States Air Force and our military here. So we have three guests, the first being Captain Joel Sherwood, who is a dear friend of mine for many years now. Joel, thank you so much for joining us.
Thank you for the opportunity. Always a pleasure, my friend.
Now, Joel, you have two other colleagues here with you, Colonel Robyn Ratcliff from Florida, Orlando, Florida. And then we have Lieutenant Colonel Reco Evans from Temple, Texas. Hi, you guys. Thank you so much for joining us. Can you, for our listeners, Joel, tell us a little bit about your background?
So I have 20 years of experience as a registered nurse. My background is in critical care, cath lab, nurse educator, chest pain center coordinator, and also highly involved in enhanced recovery. I currently serve on the civilian side as a medical science liaison for Pacira Biosciences, and also the Air Force Reserve.
And that's how we met several years ago through the American Society for Enhanced Recovery, their meeting. So both definitely involved with the enhanced recovery space. Colonel Robyn Ratcliff. Robyn, how are you doing today?
I'm doing well, Desiree. How are you?
We're doing very well. Robyn, for our listeners, can you tell us about what your background is?
Yes, ma'am. I have a couple full-time jobs, essentially. I'm an orthopedic surgeon at the VA in Orlando, where prior to COVID, we were pretty busy over there. I'd slowed down a little bit because my practice is primary elective. I volunteered for this opportunity. I'm actually the squadron commander at MacDill Air Force Base in the 927th Aerospace Medicine Squadron. So that's essentially what I do. And my other full-time job, I'm a commander of all those people. And my job there is essentially to make sure the wing is medically ready for deployment, short notice, such as what we just did.
Lieutenant Colonel Reco Evans. Hello, Reco. How are you?
Fine. How about you?
I'm doing well. Can you give a little bit of your background for our listeners?
Yes, ma'am. I'm a CRNA at the VA in Temple, Texas, and I'm also a member of the 301st NBS in Fort Worth, Texas. That's my Air Force Reserve unit.
Okay.
That's where Captain Sherwood and I, we both deployed out of. We received the, 26-hour notice?
Less than 48 hours. On the 4th, late at night, got the call out on a C-5 Galaxy aircraft by Sunday, 11:30 time. So
oh, my goodness.
Very, very quick activation and response time required.
Joel, there are many listeners out there from around the world, and so they may not understand the U.S. military. And quite honestly, I don't come from a military family as well. So to understand, being activated, being deployed, all those things can be a little bit confusing. Just can you give a brief description of what that looks like, your role in the Air Force Reserves, and then how you now are being deployed?
So it's something that comes with training. You go through, for us as registered nurses and other clinical providers, we go through officer candidate school. And we have required training through computer-based training, as well as going to specialized schools throughout the country to prepare us for things like mass casualty, being able to be deployed and set up a tent hospital downrange in things like Afghanistan, Iraq. This is obviously very unique in that we were deployed within the United States, which I think was actually the first time that has ever occurred in this way. This is very historical. So when you look at comparison to being sent downrange, where we have a process that's already established, you're being sent into essentially through a three-pronged approach. Those that through the USS Comfort supplying support, Army of Engineers setting up the Javits Convention Center and other convention centers across the country that have an abundance of patients that need to be taken care of. And then my role in the United States Air Force being to support those local facilities like Jacoby, where I'm currently working out of the North Bronx, that have been heavily hit and overwhelmed by the number of COVID patients that have come in, even to the extent of, it was kind of humorous when we first came in and got assignments where folks were like, you're going to go to rehab, you're going to go to PACU, you're going to go here, there, and then come to find out it doesn't matter where you go, it's all COVID units. There's vents on these different floors. They're all high acuity.
How many people were deployed there through the Air Force Reserves, your colleagues?
There's about 270 people that were deployed in a couple different waves here. We just got a new group of them recently, but this is definitely a kind of a joint situation as well, because I believe the Navy has about 200 people. The Army is staffing Javits and is also working out in the civilian hospitals as well. So there are significant numbers of people here to help with this. There's no doubt about it.
Mm-hmm. Oh, I can't imagine the burden that they were having then to see you guys coming in. I'm sure it was a relief for them for sure.
Yeah, and when we first got here, we saw the highest number of patients, like right as we first arrived. This is based on, obviously, the real workers of this are the people in New York City that have been fighting this from the beginning. I mean, they've been tired. They've been nonstop working with really, really sick patients, and having to take care of 2 ventilated patients in a normal schedule versus now all of a sudden, wait a minute, there's 10 people that now require care. It's really changed how we have to deliver healthcare. I mean, there's a lot of innovation that came from this as well, and there's going to be a lot of lessons learned after we get through this, I suspect. Some of it's good stuff, things that we, down the line, why weren't we doing it this way all along? But we saw the kind of the highest point of it where people were almost ventilated in ER hallways. It was that bad. But it seems like things have gone from, we're going to have to immediately intubate these patients and keep them on ventilators, to now let's try some other things we can do to try to stop them from getting ventilated, because ultimately that's probably a better course of action. So we were here at the kind of top part of that. And interestingly, I just saw a statistic today that said the number of people that haven't been able to go to work in New York City correlates with us actually being in the hospital. So it seems like we were actually really here at a good time when the New York City employees were sick, or they had, their families were sick, or they just physically can't do it anymore. We were here to support that. So I'm really proud of anybody. And, we're all volunteers. We volunteer for the military. The majority of us volunteer to come here. That says a lot about the military members that are willing to be here and help out. And I think it really has helped out the city.
It's huge. Thank you guys so much for that. Robyn, can you tell us about how it's working? I mean, are you guys going to one specific facility? I know Joel mentioned you're in the Bronx, but do you move around a lot? Or are you stationed somewhere?
When we first got here, honestly, we thought we would be at the Javits. We weren't really sure when we came what the plan was, and things change daily. I mean, even now things change, needs change. But we were kind of tasked immediately upon getting to New York City that we need to separate people into teams. So what we did was look at the city decided where we needed to go. So the Air Force, and I think the Navy did the same thing, presented packages of different providers, nurse anesthetists, respiratory therapists, critical care nurses, packaged them up and put a little bow around them and said, here's what we've got in package A, package B, package C. And then the city said, we want this one here, this one there. So we just kind of showed up at the hospital, did our quick in-processing, but it takes a couple days to kind of familiar yourself with the hospital and figure out how you kind of fit in. So as of right now, people were put in these teams and they're staying at that same hospital. I've been fortunate enough to be able to kind of bounce around to the different Air Force hospitals so I can see how they're run, and it's kind of interesting. It's New York City, the same disease, but things aren't always the same. People aren't necessarily treating this disease the same way, and it's probably because we don't necessarily know the right way. We're kind of learning here. But for the most part, the teams that have stayed with, they've been assigned, which is nice because they set up schedules and then the staff gets to know them. We've got intensive care doctors. They're running entire wards, ICU wards that came in and just took over. We've got another critical care doctor who set up a proning team, which is actually, these guys can probably comment on that as well, as one of the best things we found with this is to put people on their stomach. And that just helps relieve their lungs. But it requires a lot of man hours and brute strength. And we don't want to pull nurses away from taking care of these other critical patients. So let's get some bodies. Let's get some strong men and women to come in here and get this. It's really a procedure that you couldn't do when you didn't have enough staff. And I think it's really making a difference.
In London, we built a field hospital as a way of possibly easing the overflow. Now, luckily, we've almost not had to use it, even though it's all been set up. It's all there ready to go operational with up to 4,000 beds. But within the footprint of the existing hospitals, we've managed to keep most of it in-house. We did need it, but not up to hundreds of patients.
Right.
In New York, have you been able to deliver it within the existing hospitals?
For the most part, I mean, we have had the Comfort and we've had the Javits Center, and those have both been utilized. For the most part, this has been in the city hospitals. I would say the majority of care. I think offloading it a little bit has helped, but the city hospitals have been primarily the people taking care of it.
In respect to your most vulnerable population in hospitals, county hospitals, city hospitals, these are usually majority indigent, tend to have high risk, high comorbidities. And then you throw COVID-19 on top of that, and everything is so amplified in an institution that may not have the resources that they needed to begin with to really take on the patient that they care for. And I think some of that was exemplified by the fact that prior to coming on board, we know back in February and March is when COVID really became kind of a thing here in the States. And when we arrived in April, you had a good portion of the regular staff that were actually quarantined. And those that were there were maybe a new nurse, a relatively new nurse, and then they're put in charge of these different units. My heart really goes out to New York City and how they try to overcome and adapt and how appreciative they were to see our faces, because their foundation, their structure for process was definitely fractured by the impact of COVID-19. And for us to be able to step in and fill that gap, it took a little bit, because not only are you not familiar with where their equipment is, you're having to onboard very quickly with their electronic medical record. And some of those individuals that would do some of that natural onboarding process had to be expedited or maybe was fractured a little bit. I think that's part of that Air Force element of us kind of adapting and overcoming. And even your ancillary staff, people that do the diagnostics, the lab draws, the person that does all the ordering of the equipment for the different floors. You need an IV start kit, a Foley catheter. Some of those things would be missing in action, and you had to very quickly find out, where can I go to grab something? I ran out of body bags one day and had to think that through for a minute. These are things that I'm so glad that we had the opportunity to come out and support, because these folks had really put everything they had into trying to keep things together, and they desperately needed that support and assistance. I'm also very appreciative of Lieutenant Colonel Evans, because as we move through this process, these are unique patients. You know, I'll come into a patient's room who is sitting up, looks normal, do a SAT on them, and I've got an 82, 86% SAT. They get up and try to walk to a bathroom. They become extremely short of breath. And so it's not your traditional ARDS patient. These are not necessarily people that show the symptoms, but yet once they start using some of those accessory muscles, within a couple of hours, things are going to go really, really badly. And that's where I think Reco, or Private Lieutenant Colonel Evans, can speak a little bit to that, because the development of not only the team that pronates individuals, but him as part of the rapid response team. It's amazing what I've seen, and I think he can provide a little bit more perspective on that.
When I arrived, I was assigned to what we call the rapid response team. We show up when we have patients that are in some type of distress and the staff can't really figure out what's going on, or they may not have the time or the manpower to necessarily assess that patient. So they call a rapid response, and it's a group of us that usually shows up. And we provide primary interventions, whether it be providing additional oxygen. And now what we're doing is moving on to proning awake patients. This has been a game changer. It's preventing us from intubating patients and putting them on mechanical ventilations. You have to be pretty selective on your patient when you attempt this, because some patients, when they get air hungry, they get anxious, and it's just a downward spiral. But it really works. It is an exact game changer. 90% of our calls are patients that are exhibiting some form of hypoxia. So we show up, we provide additional oxygen, we prone them, and usually within maybe 5 to 10 minutes, their SATs are back up in the 90s. Their respiratory effort is decreased. They're markedly better. Also, you have these units that have been converted to ICUs that weren't used to being ICUs. So we provide support with the nurses that may necessarily not have dealt with a ventilator before, or titrating vasopressors and things of that nature. So the help was really welcome.
Honestly, this rapid response team is saving lives, because they're able to catch this before it gets to the point where somebody's coding and has to be rapidly intubated. And this is really saving lives. And before, they didn't have enough manpower. That those patients weren't necessarily being watched directly because they were taking care of other very sick patients. The other group of people that aren't here right now is our respiratory therapists. I think they're an undervalued healthcare provider, so to speak. And I think this deployment highlights what they bring to the table, because they're the ones that watch these ventilators. They're the ones that track these patients. They are definitely heroes in this. We wish we had a lot more of them during COVID. So I'm hoping people start hiring and maybe paying them more, because they're incredible assets to the healthcare team, no doubt.
Did you find that you guys you really are trying to put off ventilating the early intubating these patients like it was suggested early on?
Yes, ma'am. Now we are. When we first got here, the move to, immediate intubation, just because they didn't have the manpower. So the easiest thing would be to intubate, put them on a ventilator, and move on to the next one. Now that they have more help, we're intubating less ICU stays. Things have changed.
Oh, that's great.
From a perception standpoint, when you're in the middle of a crisis, you don't have the benefit of having a standardized trial for data. You're really kind of on the fly and what is working at the moment. And it was interesting to see how going from calling a code versus calling the rapid response team, that, again, this is not evidence-based. It hasn't been evidenced out, but those that would require that intubation, it seemed like they didn't do as well. Again, this is all perception, and you would hear the different nurses speak to that. Let's call that rapid response team that began to identify earlier when that was appropriate to do, and how it just seemed like lives were definitely being saved. And again, this isn't evidence-based, but for example, when we have somebody come off a vent at Jacoby, they play the song, "This Is My Fight Song," and it plays throughout the entire facility. And it's Sinatra, New York, New York, when they get discharged. It's been a real uplift to hear those two different songs played with greater frequency, since people like Lieutenant Colonel Evans and Colonel Ratcliff and those that are involved in the greater process of making those kind of on-the-spot changes in process and protocol have really made that difference. And we've seen that throughout some of the other hospitals, the New York City system as well, because you've seen publications in the New York Times and others that have spoken to this proning the individuals and getting away from that early intubation. You would see more with an ARDS patient that has less of that compliance that we see with these individuals.
So I'd say very similar experience in London. So quite a rapid transition based on our colleagues' experience in the rest of Europe, away from early intubation to doing very similar things and encouraging patients to prone themselves. The other discussion we keep having is that people started off by saying, run the patient dry, and eventually they got around to saying it's okay to resuscitate them. What's it been like there from that perspective?
Right now, we are resuscitating fluid-wise. When we first got here, it was kind of like a war zone. I mean, you had each patient, 9 IV pumps, 3 pressors, 4 sedatives. You have a maintenance fluid that's running at 125 cc's an hour. I mean, it was kind of hard to keep up with who's being fluid resuscitated and who wasn't. And as we do daily chest X-rays, and then they start to notice the changes in the radiographs. Then they start to address, okay, well, maybe this one may need to be resuscitated a little bit more, or this one a little bit less. And definitely, they were running them dry at first, but now they are adequately resuscitated. Also, chest PT. We're starting to do a lot more self-proning and chest PT, and that seems to help also.
Man, I tell you, that's back to the basic kind of stuff there, isn't it? That's what you learned in nursing school. First year in med school. But yeah, I mean, if it works, keep it simple. That's what Monty and I have said quite a bit. Yeah, Monty.
I ask one more question. Now, I can't get your full title there because I'm going to go for Robyn. Am I allowed to call you Robyn? Is that?
Yes, please.
Yeah, there we go. Because I can't keep up with all the lieutenant colonel bits so I apologise for that, Robyn.
I answered anyway. It's all right.
So your patients back home,
yes,
who were looking forward to being looked after by you, what's happening to them now? What's the plan for that?
Well, that's a really good question. I suspect I'm going to come back from this and have a lot of phone calls pending. My patients at the VA know that I'm in the military. Actually, a couple of years ago, I actually deployed again. So they kind of know that this can happen. We have not been told yet as to when we're going to be starting back at the VA, especially, as far as elective procedures. So it probably depends on if they're willing to wait for me to return or if one of my partners is going to do that. But it's going to be a very slow process at the VA to get that elective stuff back and going. But, we're doing a lot of the same thing you talked about with getting the total joints ready. We're doing telemedicine PT. Why weren't we doing that all the time? Like, I feel like that's probably something that's going to change. Why do you need to pay so much money to go out of the house to see a therapist when they can work on that with you at home? So I think there's some permanent changes that's going to change with telemedicine. I tried to do some telemedicine before I came out here to New York City, and it's a lot harder as an orthopedic surgeon to say, oh, you've got a cuff tear. I can't book your surgery yet. I also can't examine you. So it's nice to meet you. I'll see you when I get back. So it was a little harder for us to do that. But yeah, I suspect there's going to be some long lines of people that are waiting for elective surgery when I get back home.
To that point, what's life like after COVID? I mean, we've heard about what we're doing and it seems like the numbers are going down and we are going to have to get back to life as, well, probably not as we knew it before, but some semblance of that. What is that going to look like from your all's perspective?
By the way, I call everything BC, before COVID.
Before COVID.
Before COVID. Now we're going to have an AC situation of how things are going to change. I don't know. What do you guys think?
No idea.
I personally wonder, so, different trends in the past, such as baby booms after crisis. Are we going to have another baby boom? And if there's any validity or potential for resurgence of COVID, how do we practice then? Are we thinking in regards to enhanced recovery, where there's the opportunity to maybe minimize that time in the hospital, thus minimizing time and exposure and resources? I think about opioid minimization. I think about the U.S. Surgeon General. And prior to COVID-19, there was a lot of discussion around making sure that we addressed that horrible killer out there that was taking 130 plus lives per day. And now U.S. Surgeon General, definitely the focus being on COVID-19. How do those two things mesh once we have truly gotten beyond the curve and are back into the hospital practicing? Is that still going to be in place? All that hard work and energy that was put in place. So I think a lot of those things need to be taken into consideration.
I think we've all accelerated our understanding and our ability to use, like the technology. We're all chatting away to each other at the moment. Our listeners won't know the fact that we're actually on the screen and we're all chatting away very successfully, looking at expressions, and you're all wearing your masks because you're actively deployed in the field. I think a lot of that's just not, as Robyn just said, is not going to go away. If you see me, which in a good way, I think we'll embrace the e-technology side of things. It's also, when we started this journey about COVID-19 from the front line, we hoped that as part of the reboot, so we call it Surgery Reboot Camp now that we're all going to, is that everyone would take the opportunity to embrace enhanced recovery principles, which is where Joel, you and Desiree first met, I think.
Yeah. Yeah, I mean, we've talked about this several times. How are we going to employ those types of, all those ideas that we know work really well, but get those out kind of on a, to get people using them again, and then optimize patients before they come in and then get them out of the hospital sooner. But how do we scale that up too? I think it's going to be really important. I think we have a huge opportunity right now. Like I said, there's a huge bank of people just waiting to have surgery. Let's try and get to them now and talk about what they can do before they come into us to help optimize and improve their likelihood of getting out of the hospital much quickly. Because in the instance of COVID, I don't think anybody wants to still be hanging around in the hospital to recuperate and recover.
Absolutely. And we're even thinking about strategy. There's been a lot of focus on the OR space with COVID-19 and aerosolization, and thinking beyond, if we are able to minimize adverse events that might require intubation in a patient room, which then puts everybody at that same risk, or even other things that require more frequency in that patient room that might expose nursing and other healthcare providers. I think getting our mind wrapped around quality care, but also what is the most bang for the buck in terms of that exposure that you're going to invest in that patient room should definitely be considered in addition to our PPE gear and our masking and those different things. And then going back to how long do we, keep them in the hospital? Is there an opportunity to reevaluate that based on nosocomial infections are very real, and COVID-19 might be one of those opportunistic infections that can occur in that space. So single shot blocks, different things of that nature might really be important. Or to your point, Desiree, optimizing that patient before they come in. So maybe that patient that's having that total knee done may not be as problematic, getting that BMI, that A1C, and those different things under control. Those are definitely some things I hope to see come out of it.
Absolutely. Well, guys, just our final point here. Is there any, kind of take-home messages that, me sitting in Louisville, Kentucky, getting ready to start doing elective cases again, and, we probably are through kind of the major crisis for here. And I know in throughout the U.S., most places are kind of seeing a downturn in their distancing has worked, and we flatten the curve. Any words of advice that we can get from you guys going forward? Robyn, do you want to start?
I would just say that, before I got here, people, and even myself, you hear different media outlets and you're like, is it really that bad? Is this real? I mean, it's hard to really see what it's like until you're on the front lines. And my statement is yes, it's real. There are sick people. It can get people very sick. Yes, there's some people that aren't going to get sick, but it's a real problem. The issue is going to be that it's not going to go away, and how do we move on with a life with it? So come October, it's not just COVID, it's influenza. There's it turns out there are other pulmonary diseases besides COVID that at some point we're going to have to remember how to reevaluate. And we're going to have to separate the two, but we're going to have to figure out a way to move on. And I certainly don't have all those answers, but people get very sick. It is real. New York was hit. There was no doubt about it. But we just have to move on and get back to somewhat of a normal life, AC, after COVID. So
yeah. Lieutenant Colonel Evans, what about you? Do you have any words of advice for us, especially when it comes to direct patient care?
I think this would be a good time to reset and start taking better care of ourselves, because you wear your N95 daily, and you have this on top of your N95. After a while, you notice that your breathing starts to get a little bit more labored. Things that may put you in better shape than where you are. I think if we would just take that approach, take better care of ourselves, so that way we'll be around to help take care of others.
Yeah, absolutely. And Joel, as a nurse, as someone there on the front lines there and going forward, any words of advice for our listeners?
I just think in terms of one, I echoed the remarks of my partners here, but also thinking more strategically. This is the first wave, and there's a potential second wave of COVID-19. And even if that doesn't necessarily occur, there's a certain percentage of the population that are going to be affected, and we've identified who those vulnerable individuals are. And I think being mindful of that in our interactions and protecting ourselves and protecting those others that are valuable to us and those that we don't know, that shows mutual respect. Then the other being that once we have truly gotten past the curve, there's that need to address all of those elective cases that are going to be needing to be done. And thinking in terms of throughput, thinking about time and energy that's been invested in these enhanced recovery protocols that didn't happen overnight. You and I know from working together that sometimes it can take years to really get it perfected, and they're very costly to get down into that point where you actually see return on that investment. So I really hope that that's something to take into consideration, these different facilities that have been hit so hard. And I'm extremely appreciative of all the hospitals that have functioned the way that they have, considering the effects of having all of the elective cases pulled, and then further complicated by the amount of COVID high acuity cases that are coming in, that there's going to be an opportunity to better manage those individuals, and that has to be part of the discussion going forward, respectfully.
Yeah, absolutely. Colonel Robyn Ratcliff, Lieutenant Colonel Reco Evans, and Captain Joel Sherwood, we cannot thank you enough for taking the time out, especially where you guys are there in New York City, the epicenter of the COVID crisis here in the U.S. Thank you for sharing your experiences. Thank you for sharing your time. And thank you so much for your service.
Thank you for having us, Desiree. Monty, nice to meet you.
Very authentic. No.
I'm getting called from overhead.
Bombing raid. We're good.
Yeah.
All good.
Top Med Talk.
All right. Well, guys, we truly do appreciate it. And thank you for listening to Top Med Talk. If you want to find more information, you can find us on topmedtalk.com. Or find us on social media, your favorite social media platform, Twitter, LinkedIn, Facebook. We are there. Stay strong, stay well, stay healthy. We are all in this together. We're going to get through it. Thank you so much for listening.
Top Med Talk is proud to thank its sponsors, specifically Edwards Life Sciences, for their generous support through this global crisis.